Good morning. Welcome to our ATHENA Scholarship Day. I am Erin Young, Assistant Professor in the School of Nursing and Assistant Director of the Center for the Advancement in Managing Pain, often referred to as CAMP. You'll see that a few times today. Really awesome. And I'm a member of the ATHENA Planning Committee, and on behalf of the school overall, and the committee in particular, we extend our heartfelt greetings to all of you today. And I would just like to personally say, I know it's less than 2 weeks till graduation, and so I appreciate that you are awake and excited to pay attention and to be a part of today. Those gathered here for our Scholarship Day include our very bright and talented students, representing the varying levels of study, our undergraduate senior class members representing their evidence-based practice projects based on their research, our junior class members who are engaging in the day of scholarship by completing a class assignment of engagement, review, and judging of the research posters. So be nice to the juniors even if you aren't online. Our community health students, honor students, independent study students, research fellows, students, innovation students, and doctoral level students who are completing doctoral program research requirements with their poster and podium presentations today. Other members of our community have come today, including professionals in the field, and will earn professional education credits. We are anxious to showcase the work of the UConn School of Nursing's research efforts in many areas of study, but most importantly, we wish to take part today in the scholarship of chronic illness and vulnerable populations. I wish to note that there is a slight change to the schedule, of course. This portion is now scheduled to 9:45 rather than 9:30, but other than that, it should be seamless for you. We know Dr. Jacobs' class will leave us after the keynote and return for the afternoon session. Anyone who is in Dr. Jacobs' class needs to go to the registration desk to pick up their certificate of attendance at that time when you leave from the morning. Before we progress through the day's activities, which are numerous and all exciting, I wish to thank our sponsor, the Mu Chapter of Sigma Theta Tau. Please visit the chapter table outside of the Student Union Ballroom as you go upstairs today for the other sessions. Lastly, we wish to extend our thanks to the staff in the School of Nursing who have helped to make this day possible, and also to the graduate students who have supported the day throughout this process. Sorry, you'll probably have to clap again in a second, so don't put your hands down. Now, without further delay, I wish to introduce you to our leader, our dean, Dr. Deborah Chen.
Thank you, Dr. Young. Good morning. I am Deborah Chen, Dean of the School of Nursing, and as I welcome you here today, I will tell you that this is my very first ATHENA Scholarship Day. I joined the school as Dean in January of this year. It has been such a wonderful first semester at school for me during this past semester with all of the robust activity that is occurring here. It's very exciting, both among our students as well as their research faculty, instructors, and mentors. And it makes me so very proud to host this event. As Dr. Young mentioned, the theme this year is chronic illness and vulnerable populations, a critically important topic. In September 2011, for only the second time in its history, the UN called a high-level meeting on a specific health priority, the first one, of course, being HIV/AIDS. And in this case, the growing burden of chronic non-communicable diseases. The outcome of the meeting acknowledged that the global burden and threat of chronic non-communicable diseases constitutes one of the major challenges for development in the 21st century, which undermines the social and economic development throughout the world and threatens the achievement of internationally agreed development goals. Furthermore, chronic non-communicable diseases are a threat to the economies of many member states and may lead to increasing inequalities between countries and populations. Those of us who have spent our entire careers trying to prevent and manage chronic disease cheered, and we said, it's about time. This recognition was long overdue, because we know that throughout the world, 60% of all deaths are due to chronic disease, with cardiovascular disease being the #1 cause of death for the foreseeable future. In addition, we know what the risk factors are for chronic disease, and they are similar across most chronic non-communicable diseases. There is no reason for inaction, and I challenge all of you to make prevention of chronic disease, wherever you are, with whatever population, a priority. So, to be able to spend a day focusing on chronic disease in vulnerable populations is extremely timely. And we are so very pleased to welcome a scholar in this area as our keynote speaker today, Dr. Cynthia Holle. Cynthia Holle is a registered nurse and holds a doctorate of nursing practice and master's of business administration. She received her DNP from MGH Institute of Health Professionals and her MBA from Western New England University in Springfield, Massachusetts. Dr. Holle earned her BS in Healthcare Administration from St. Joseph's College in Maine and an associate degree in nursing from the University of Bridgeport. Currently, she is a postdoctoral Advanced Health Services Research Fellow at the Providence VA Medical Center's Center of Innovation in Long-Term Services and Supports, CTSS COIN for short. And she is the Vice President of the Connecticut Nurses Association, member of the National League of Nurses, the Connecticut League of Nurses, and Sigma Theta Tau. Dr. Holle's professional experience includes critical care and long-term nursing and healthcare administration in acute, post-acute, and managed care settings. Her emerging program of research involves clinical workforce development and support of vulnerable older adults in post-disaster shelters, including recognizing and managing delirium, dementia, and depression in the shelter population. Dr. Holle's DNP scholarly project examined barriers, incentives, and beliefs about academic advancement for directors of nursing in skilled nursing facilities. As a member of the Connecticut Nursing Collaborative Action Coalition, she co-authored an online education unit on population health for nursing students, faculty, and practicing nurses, which is free and hosted on the Connecticut League for Nursing website, so perhaps everyone needs to check that out. Her areas of interest include population health, healthcare policy and advocacy, and leadership development for nurses. She is a volunteer disaster health services nurse for the American Red Cross and has served on 3 national disaster responses. Please welcome Dr. Cynthia Holle.
Good morning. Good morning.
Morning.
I am 2 weeks from graduation. Who's graduating? Let's see, show of hands. Oh my gosh. Congratulations, we need you. We're so happy to have you joining the workforce. How many are pre-licensure? If you're first time, you're not already a registered nurse, pre-licensure. Great. That thrills me. How many graduate students or PhD students do we have graduating? Okay. Wonderful. I like to know my audience a little bit. You're all the population, so I'm trying to figure out what population you are. Thank you, Dr. Chun. Wow, you made me sound better than I feel like I am, so thank you. A lot to live up to. I'd also like to recognize that Dr. Lisa Sundin is in the audience today, and she has been our leader in the Action Coalition. Lisa, wave to everybody. So the work that we have done has been under her excellent guidance. By the way, if I cry today, it's not out of love for my topic, which I do indeed love, but allergy season has been just awful. Is anyone else affected? Because I've got Kleenex to share, feel free. So thank you again for having me and allowing me to speak about this very important topic. What I want to stress to you, in spite of that wonderful welcome, that made me sound so great is I worked in a setting where ordinary people can do extraordinary things. Now, the people that co-authored those modules on population health came from all walks of life within nursing. People who were very experienced, people who came from academic settings, former dean of this university, to a student, a nursing student. And we all had different interests within nursing, but we came together to work on a population health effort. So we consider ourselves average nurses. If we can work together to create something of value within this world of a culture of health, you can too. Everyone here has that potential, and I'm going to encourage you today to recognize that potential. As we start, I have a few disclosures to make. As Dr. Chun said, I am a fellow, a postdoc fellow with the VA. Anything I say here today is entirely my own opinion and does not reflect the VA. They've been good enough to allow me to have the day to come and speak with you. I'm not an expert in culture of health or population health. I'm a lifelong learner, and I'm on this journey. I'm going to invite you to join me on the journey, but I am growing and learning as you are. I don't consider myself an expert, just a person with a passion for the topic. Also, that course that we developed is being hosted on Connecticut League for Nursing website. It was developed with money from a grant from the Robert Wood Johnson Foundation. It is free. Please, if you get a chance, log on, take a look. I invite you to take the course. We're pretty happy with the way it turned out, although we are working now on Population Health 2.0 to move forward and continue to grow this offering. And as Dean Chung did mention, I am the Vice President of the Connecticut Nurses Association, so a quick plug. It's your association. We invite you to join. We have a group for young professionals that you might enjoy to help with your transition into practice. And if you're interested in advocacy, we have a very active government relations committee that provides testimony at the state capitol and helps to advocate for the health of the public and the occupation, the career of nursing and of nurses' needs. So please check us out. So what is a culture of health? How do we define that? There are so many definitions of culture of health. It means different things to different people. So to do a little bit of level setting, I just want to talk to you for the first half of my talk this morning about some definitions and some background, and then what I really want to do is just talk with you. I'd like you to engage with me and just have a discussion on culture of health, population health, and how we address chronic illness. So this is one interesting definition, that culture of health is good health and well-being that flourishes across geographic, demographic, and social sectors, fostering healthy and equitable communities. I think that's a pretty straightforward definition. Does anyone have a definition they like better? Yeah, I didn't think so. I want to talk to you a little bit about this culture of health action framework, because this is what my talk is focused on today, and this grounds what I'm going to tell you. I also want you to remember this image of a circle, because we're going to be speaking about circles today. You'll see here that all of these drivers really focus on improving population health. So population health is the core of the outcomes that we're going to be discussing. So action area 1 is making health a shared value. It has to be important to everyone. People have to appreciate the importance of making that a shared priority. And the values behind health and wellness differ from person to person. Just as an exemplar, if you go home and you email your friends or post something on Facebook and say, what do you think health is? Or do you think every American is entitled to health care? Is health care a privilege or is it a right? You'll get a variety of answers, and it really depends upon your audience and who you ask. For the individuals that I have worked with in our population health endeavor, we see health as a right, not a privilege. If you ask some members of my family who might be a little more right-leaning than I am, they'll tell you that health and health care are not a right, they are a privilege that you have to work for and earn. It makes for a pretty tough gathering at holidays and so forth, because my views are very different. But you have to know your audience when you're talking about the value of health. Fostering cross-sector collaboration is a really important part of this framework, and in my opinion, it's probably the most challenging. I think building bridges between organizations and finding common value sounds good on the surface, but can get very, very difficult when you get down to the details. I'm really excited to go to a program tomorrow at Connecticut Hospital Association that talks about building these bridges and having that collaboration. So creating healthier and more equitable communities is action area number 3 in that circle that I spoke about, and it really addresses environmental and policy conditions. And I think this is where a lot of nurse advocacy comes into play. It's an important area in this action framework. And then strengthening the integration of health systems and services. As Dr. Chun mentioned, we spend a tremendous amount of money on chronic health care. We spend very little on prevention. Most all of our money goes to acute treatment, acute care. I think it's something like 3 to 6% on prevention and community health initiatives, and in the 90s on acute care. So that's an area that's of importance to us in really affecting this framework. When we look at that culture of health, it's not achieved by focusing on each action area in a silo. They all have to work together. They're interdependent to create that outcome in the center, improve population health. So keep that in mind as we continue to talk about these circles. Just a little background on that action framework for you. We need a commitment to equity. Again, equity is different to different people. As I mentioned before, depends upon your audience, what people see as equitable and fair, particularly as it deals with multicultural perspectives. Here, this is a quote from the Robert Wood Johnson Foundation, by the way, and we view the Robert Wood Johnson Foundation as our guiding star in our effort to improve and drive a culture of health and improve population health. Almost everything that I have here today from Robert Johnson, I've included a link for you, and you can have my notes on my slides if you like. So a culture of health, a healthy nation cannot leave anyone behind. It's time to embrace a more integrated, comprehensive approach. Whenever I read this, I picture soldiers on a battlefield with that imperative of leave no man or woman behind, that we are only as strong as all members of our society and our populations can be. So this is a very important concept to me. So what is health? And let's define some of our terms in order to understand how we can drive that culture of health to overcome chronic illness. What is health? Again, it's a word that means different things to different people. Is it truly a state of being free from illness or injury? Is anyone ever completely free of illness or injury? I would say probably not. The World Health Organization defines health as a state of complete physical, mental, and social well-being. What do you think about that? Do you agree with that? Talk to me. Yes? No?
Yes.
How many people agree with that? Okay, a few. So I think who is completely healthy, as I mentioned. I think we can take that definition a step further and define health as the ability to adapt and self-manage in the face of social, physical, and emotional challenges. So it's that achievement of a state of equilibrium, of being able to adjust to whatever your health issues might be. I've learned some very interesting lessons from 38 years in nursing, and that's that people will accept and adapt to just about any health circumstances put in front of them. I think everyone wants to be healthy and wants to live a life free of challenges. I think people want to be able to be well enough to perform their own activities of daily living, be independent and autonomous. But with every illness that a person endures, they're willing to trade a little bit of that independence or make concessions so that they're able to carry on their daily lives. I think people will live in a very compromised type of fashion. And I've seen people in intensive care who are critically ill and will make the decision not to be a DNR because they're willing to live under any circumstances. So I think health is very, very subjective. And here's that equilibrium that I spoke about, that equilibrium between the individual and his or her environment. So I think that I really was drawn to this particular quote from an article that talks about changing the paradigms of health and disease and designing strategies for future work. And that this need, of course, is very urgent. When we talk about population health, as you remember, is at the center of that circle of the action framework. Population health is the study of well-being among defined groups. This is a definition put forth by a very august group of population health devotees. It was our Action Coalition group of 6 people who created those modules I was telling you about. We looked at definitions of population health from several different prominent authors, and we decided to boil it down to something very simple and easily remembered and meaningful to the individuals who'd be taking our online course. So that's our condensed version. However, this is the version that comes from a textbook on population health by very well-known authors. As you can see, it's fleshed out a little bit more. It's got some more detail. It talks about that those health outcomes of a group of individuals, including the distributions within the particular groups and patterns of health determinants. And we're going to talk about health determinants a little bit too. When we talk about population health, we talk about circles. Here's the circles again. So those of you who are graduating in 2 weeks, you're a population. People who are graduating who have blue eyes, you're another population. Just like the child who lives in a high-rise in New York City who has asthma is a population. So populations exist wherever you draw circles. And in your practices, you will draw those circles around your populations of interest. Whether you work in pediatrics and you are taking care of children with asthma, or you work in community health and your population might be factory workers in the city of New Britain, or whether you work in gerontology and your population could be older adults with a history of falls and hip fractures, you can draw those circles around your individual population as you move forward in the care of that population. So populations are not predefined, they're what you choose to make them based upon the needs that you see. We're going to talk a little bit about upstream determinants of health. And I had a video to show you that didn't embed quite well, so I'm going to tell you a story instead of play the video for you. I'll give you the condensed version. I'm not a storyteller, but hopefully you'll get the gist of this particular story. So the story begins with a group of people, group of healthcare workers taking a hiking trip, and they are hiking alongside a river. It's beautiful, it's out in the country, tall pine trees, gorgeous setting. And all of a sudden, someone is drowning. Someone comes floating down the river, and they're screaming, they're waving their arms, and one of the health researchers, health workers, jumps in and saves the person and pulls them to shore. And a few minutes later, 2 more people come bobbing down the river, drowning. And more people jump in to rescue these individuals. Pretty soon there's a steady stream of drowning people floating down the river. And everyone on this hiking trip is pulling people out of the river, administering first aid, and trying to take care of them as best they can. It's getting very, very busy for this group, and the leader of the group looks up to see one of her coworkers leaving. And she says, "Where are you going? We need help. People are drowning." And the woman who's walking upstream says, "Somebody's got to go upstream and figure out who keeps throwing these people in the river." So that person who is going upstream to figure out why people are ending up in the river is an upstreamist. It's an example of upstream thinking and of prevention, where most of our dollars and our efforts are focused being downstream, where we are treating people who arrive on our doorstep with both chronic and acute illness, and we are not driving that upstream thinking that looks for prevention and creating cultures of health and wellness. So keep that in mind, that those upstream determinants. Can you think of some upstream determinants today? What do people in communities and populations see as upstream determinants of health and well-being? Anybody? Zip code, that's a good one. And in Boston, it's not just zip code, it's T-stop. Where I went to school, you can track people's health outcomes based upon their particular, you know what the T is, right? It's the subway in Boston. Okay. Anything else other than zip code? That was a good one. How about access to food? How about food insecurity? Do you know about that? So some neighborhoods don't have grocery stores where you can buy fresh food. How about another one? Can you think of another upstream determinant that affects health?
Air quality.
Air quality is a good one, especially for people with breathing disorders, asthma. Employment. Employment is a big one. Employment gives us access to health insurance sometimes. So it can be employment, your zip code, ability to get transportation. What if your provider, the only place you can get health care is clear across town and you don't have a car? Maybe you can't afford that, and there is no bus that stops in your neighborhood. That's an upstream determinant that's very important. Your level of education. People who are better educated have better health outcomes and access to care. So those are just a few. There are numerous upstream determinants of health. So when we talk about population health, we have to be careful that we're talking about the same thing, because different people will use this term differently. It's sort of co-opted in some segments of our work, and I think you'll see things like disease management, you'll see case management, and you'll see care delivery models like accountable care in medical homes. So for instance, when I talk about population health to my supervisor, who's a physician, he's like, no, I don't want to, that's not what I'm interested in, because to him, population health means disease management in a managed care setting. There are managed care organizations that have divisions that are referred to as population health, but they used to be called disease management programs, or sometimes case management. I looked at a job posting once that was labeled population health, and I got really excited. Wow, jobs in population health. It was case management, and that's not to say that case management is not valuable. It's incredibly valuable, particularly when we are looking to foster that culture of health. But the terms are not always used in the way that we use the terms, particularly in my small work group. So it's important to understand the meaning of population health when you're talking to people about it. So what is chronic illness? Now we get to the heart of today. We talk about chronic illness. I'm really looking forward to hearing presentations, and I'm hoping that I can stay and look at posters. But chronic illness has a wide range of definitions also. Does it matter how long you're sick to be called chronically ill? Do you have to feel sick? Do you think some people have disease that are asymptomatic, where their symptoms are so well managed that it doesn't present a burden to them on a day-to-day basis? Who decides if you're chronically ill? Is it your physician? Is it policy? Is it based on public health definitions? Or what we determine here in academic settings? Who gets to decide what chronic health is? Does it apply just to specific diseases? Does one disease make the cut and another one doesn't? It really doesn't matter so much to you if you're the individual who's ill, whether you have an illness that fits in a predefined category or not. So it's very nebulous, I think. And is it based on cost? Do you have to be ill with a disease that has a tremendous impact to financing, particularly at the policy level? So here's one definition of chronic illness, that it's a condition that lasts a year or more, requires ongoing medical attention and limits activities of daily living. That's pretty straightforward, don't you think? Another definition includes the idea thoughts. Do you disagree?
Many people, like myself, who study chronic pain fits into this nebulous area where a lot of people are trying to say this is the disease in itself. Which traditionally talks about as symptoms. Yet, symptoms of what? You can't figure out why we have chronic pain and all that. And so I think chronic pain fits into this nebulous area. It doesn't fit the box.
It doesn't fit the box. And does chronic pain morph into substance use disorder? Is that labeled as a disorder, a disease, and now it's not a symptom anymore of something else? Yes, sir.
Similarly, movement disorders, mental health issues,
Oh, mental health always gets left behind, doesn't it? An area of tremendous need that has tremendous inattention, I believe, at the policy level. I noted Alzheimer's disease in substance use disorder, so thank you. So the National Health Council reports that the economic burden from the most prevalent chronic diseases is 1.3 trillion, trillion with a T, not billion, not million, trillion. Huge cost. When we talk about cost of illness, by the way, this falls into the category of health numeracy as well as health literacy. I think that this is an area of tremendous change in the practice of nursing. When I went to nursing school the first time 38 years ago, there were 3 things we couldn't do or speak of. One, and I went to school in the South, in South Carolina. We could not catheterize male patients. We could not finish the bed bath for male patients. We had an orderly who stayed in a utility room until he was called out to finish a bath. And we couldn't talk about the cost of health care. We couldn't talk with our patients if they had questions about their insurance coverage, things like co-pays or deductibles and so forth. That was not allowed. Nurses were not allowed to do that. So 38 years later, times have truly changed. If it pees, I can cap it. I'll hit it the first time. Bed bath, what is that? We don't even do that anymore. We hand patients a package of moist towelettes that have been microwaved. And I can talk about health care costs. I am comfortable, I'm not an expert, but I'm comfortable talking about cost at both the individual level and the systems level. And everyone who graduates from nursing school today should have basic education in healthcare financing and economics. You should know, thank you, you should know what a copay and a deductible are. You should understand the basics of managed care. You should know the impact of cost on your profession. And let's take a look at nursing in general. Boy, are we a cost center or a profit center? We fall under a room charge, don't we? So I think it's important for every nurse to be able to have at least a basic education in healthcare economics and finance, because it impacts you, it impacts your career and your livelihood, and you need to be able to advocate for your profession as well as the public. So that's my soapbox on cost. So when we talk about the cost of chronic illness, 86% of our 2.7 trillion annual healthcare expenditures are for people with chronic and mental health conditions. Sometimes at least mental health is included in the figure. And by the way, if you start researching cost figures, you'll come up with different numbers from different organizations, maybe for different time frames or different statistical methods or different categories that are included and excluded within that cost system, but you'll get some basic idea of the tremendous cost of chronic health care today. So those at the highest end of the scale, 5 or more conditions, 12% of the population, but 40% of the health spending. That's no surprise to us, really. It's sort of a takeoff on that 80-20 rule. The people who are the sickest cost the most. So when we talk about cost of chronic illness, here are some examples of how much chronic illness costs. Cardiovascular disease, $316 billion, billion with a B. Cancer, $157 billion in 2010. Diabetes, diagnosed diabetes. How many people do you think are walking around today with undiagnosed diabetes, with health issues? I think it's large. I think there's a large amount that don't know they have diabetes until they become really sick. Arthritis, gosh, I don't even think of arthritis as being in the top tiers of chronic illness that have a financial impact on the nation. But I would guess maybe a good percentage of that comes from lost productivity, but also the cost of medications. Obesity, $147 billion. This is the sin slide. Smoking, $300 billion. And drinking, how about this? Alcohol, $249 billion, or an additional $2.05 on each drink. What if you had to pay a tax for every alcoholic beverage you consumed of $2 to cover the cost of that care for chronic illness driven by drinking? So the CDC lists chronic disease as the leading cause of death and disability in the U.S. In some ways, we're a victim of our own success because people who have survived acute illness in their younger years live long enough to develop chronic illness. As I told you, I'm not an expert in population health or culture of health. I'm a lifelong learner, but I'm an expert in the care of geriatric horses. I grew up on a horse farm, and I have taken care of horses that lived past their estimated age of departure. The American Quarter Horse Association declares horses dead for their record purposes at 30, but I've had 2 horses that lived into their upper 30s. My mother, who is an expert, will tell you that if they live to 20, they'll live to 30, because by 20, a horse, if they have survived, they've passed all those potential pitfalls of acute illness or injury, and now they're moving into the realm of chronic conditions. So it's really not that different for the human population. We can survive acute accident, illness, injury, and so forth, to live longer, thank goodness, but then we are faced with chronic illness. Anybody have horses? All right, if your horse gets over 30, call me. When we talk about the prevalence of chronic illness, I use 2 different sources just to look at prevalence statistics. The CDC and RAND, both are well-known organizations, and their numbers are somewhat alike in some areas and pretty different in others. So in terms of having 1 or more chronic health condition, somewhere between 50 and 60% of American adults. And then when we talk about 2 or more, 25 to 42%, there's a bit more of a spread there between these organizations. And then RAND tells us that about 30 million people are living with 5 chronic conditions or more. 5. Can you imagine? 5 chronic conditions. 30 million people. Anybody know the population of the United States? Somebody's got to know. Anybody? It's not a quiz. It's around 300 million, right? So, do the math. When we talk about prevalence of chronic illness, 7 of the top 10 causes of death are from chronic diseases. 2 of them, heart disease and cancer, accounted for 46% of all deaths. Now, that is not to say that intensive research is not going on in these 2 areas, cancer and heart disease, but we're not there. We're making strides, we're applying that research, and we're seeing improvement in care, but still, we need to look toward the upstream determinants, because it's not enough just to fix people who are broken, to fix people when damage occurs. We really need to be upstreamists and think about how to head those chronic diseases off at the path. So just to cap up talking about cost a little bit, remember when I told you you have to know your audience when you're talking about a culture of health and chronic illness and population health? That people like me who lean a little more to the left side of the world, we get it, I'm there. I want this health and well-being for everyone. The people like some of my more right-leaning family members really need to hear different explanations for why this matters. And so when I tell people who don't see the world quite the way I do, and I admit my left-leaning bias, I'll say, if you don't believe in fostering a culture of health or driving population health for everyone, regardless of their ability to pay, whether or not they're working, whether you feel they're deserving in one way or another. If we don't take care of everyone, those people will make you sick. So people whose chronic health needs are not addressed are the people who are overutilizers of emergency rooms for primary care. They will be huge users of uncompensated care. Your hospital and healthcare systems are burdened by people's inability to pay, and that gets rolled into your managed care rates. I've worked in managed care, and so the folks in hospitals who determine what the charges are going to be on an annual basis for their services will take that uncompensated care and roll it into the rates that you have to pay or that your healthcare organization, your managed care organization pays. Not to mention, if people are chronically ill, you run the risk of catching something from somebody whose healthcare needs have not been met. So if you're an employer, your employees are sick, you'll have decreased profitability because you have decreased productivity. So you really have to understand your audience when you're making the pitch for improving the health of the entire nation. So let's talk a little bit now as nurses, as drivers of a culture of wellness. I decided to take your topic, chronic illness, and sort of turn it around and talk about chronic wellness, because I think this is the great untapped power of nurses. I think it's something that's foundational to us, to our particular occupation, and I think that we are moving full circle to really recognize nurses' power in driving chronic wellness. Because we are educated to understand those social determinants of health and intercede and really promote wellness upstream. We're all educated to be upstreamists. So I think one of the first things we need to recognize is that we need to practice the 4 population-focused competencies. And I'm going to give you just a high-level overview of that because I think it's pretty important. The first is to take a holistic approach, and I know that you all do this, to consider the physical, mental, social, and spiritual aspects in the context of an environment. Can anybody relate to this maybe in your coursework on public health, community health? This is something that's really stressed in community health courses. Am I right or am I off the mark? Okay, maybe you don't remember. Don't know. But I didn't want to take community health when I finished my last degree, but I had to take it. I had a gap. And I thought, oh, let me try and get out of taking community health, and I couldn't. I had to take it. And let me tell you, I loved it. I thought, why haven't I done this years ago? This is a fabulous course. The work that I did was so valuable to my community, and it really, to me, was the essence of nursing, because you're really out there among people trying to make an impact in an upstream way. So if you haven't taken your community health course yet, I hope you enjoy it. When we talk about coordination of care across providers and sites of care, we tend to think of coordination of care within health systems. So those care transitions of people moving from hospital to nursing home to home care, that's certainly very important, but we also have to look for coordination of care across providers that are not within the same system, or that maybe are not health providers. It's very dependent upon the individual patient or family or community that you're working with, who your client is, but that coordination of care is vital. We can't operate in silos. If for the very least reason, accidents happen. When patients move between levels of care without good care coordination, things like medication reconciliation can fall by the wayside. And this is the most error-prone time in a patient's encounter with the healthcare system. We need to collaborate with other professionals and community stakeholders. Interprofessional collaboration is a huge topic in nursing education right now, and not just among healthcare professionals, but I think one of the most interesting collaborations I've seen is at Arizona State University, where the sim lab consists of actors from the drama department, students who are acting out different illnesses for nursing students, instead of just having the mechanical simulation, I don't like the word time, but you know what I mean, the sim people. What do you call them? Mannequins, thank you. Where they actually use actors, and there's benefit there both to the students in the drama department and the nursing students. It's a very interesting collaboration. And then advocate for the individual and community. And when I talk about the work of the Government Relations Committee at the Connecticut Nurses Association, this is an excellent example of advocacy. So how do we make all that happen? We have to start with nursing education. So we need to make sure that population-focused concepts are integrated into the curricula for all nurses, both at the undergraduate and graduate levels, according to the level of the student. And we need to make sure that faculty are prepared. This is huge, because we can't expect people to teach something that they haven't had exposure to. We need to be able to fund our professors' education in population health and allow them time to sort of take it to the streets and practice population health a little bit, get out and learn and grow, and be able to come back and share that wisdom with students, or to learn with students. We have to make sure that students are practicing in a team-based environment. And then we have to transform nursing practice. It's so challenging to talk about transforming nursing practice when nurses in, let's say, acute care, because I think when everyone thinks of nursing practice, they think acute care first, are working very hard, very long hours, very sick patients, and 12, 13 hours at a time. And by the time they get home, they're exhausted, and they don't want to sit down and log on for online education and learn about population health or any other topic. We need to find a way to reach those nurses and help them incorporate population health into their practice that's going to be compatible with their lifestyle. It's a challenge. I don't have all the answers for that, but we need to give thought to that. We need to collaborate with other healthcare providers. This is consistent through each of these different transformations that I'm telling you about. Collaboration is everything. And we need data-driven decision-making. So data are knowledge, knowledge is power, and power translates to action. So gone are the days when we can say, gee, I think that worked, I think I'll try it here. Now that worked before for this patient, I'll try it on that patient. With the advent of electronic health records, we have such rich data at our fingertips that we really need to make the most of our relationships with our nursing informatics specialists to be able to have access to that data for our own research, whether you're researching in a formal capacity or you're conducting research and using evidence-based practice in your practice. We have all that data, so let's use it because it's so valuable. It elevates us as a profession also, if we can move from anecdotal care planning to data-driven care planning. And when we talk about population-focused nurse leadership, we talk about those nurses who are directors or CNOs, leaders in their fields. We need to make sure that they are incorporating the concepts of population health in their practice. So part of that is really understanding who are your customers, what are their needs, what are their upstream determinants, how do you engage them and advocate with them, teach them to advocate for themselves, and learn from them. So wherever you practice, if you're a nurse leader, you really need to understand the population that you're serving, what their upstream determinants are, what their experiences are with chronic illness and disease, and incorporate that into all your leadership strategies. We don't exist for our own sake. We're there to serve. So when we talk about engaging the nursing workforce, we need to talk about research. We need funding. We need money for research, and it's so hard to come by. I am the first and only nurse, postdoctoral nurse, and my research point in the VA. There are 5 of us across the country, and the VA has made a commitment to fostering nurse research by including a funding mechanism called the Nursing Research Initiative. Most postdoc fellows who are researchers in VA coins compete twice a year for career development awards. And I think maybe 40 to 60 applications are submitted in each cycle, and maybe 20 to 30% are funded. The Nursing Research Initiative is an award only for nurses within the VA system. And I think on the last cycle there were 2 applicants. But that money is protected just for nurses to really drive the growth of nurses in research. It's very, very important. I think this is a time when our country is shrinking the funding for scientific research. And I have a bias. I have children who are postdoc researchers, stem cell bioengineers, who are very discouraged about the outlook for research in this country. So when we talk about advocacy, part of our advocacy has to be for research funding. We need rapid dissemination, and this is an absolutely essential component. I think it's a great opportunity to create dyads to carry on research and implementation, particularly in a university like this where you have a PhD program and a DNP program. What perfect partners for conducting original research and disseminating it in a very rapid fashion. You've got 2 different terminal degrees with slightly different approaches and functions and roles, and a dyad like that can really do terrific things and do it quickly. I would encourage anyone that's looking for a research partner to team up in a group like that. We need to continue to develop the pipeline of nurse researchers. We need to make sure that nurses, nursing students, doctoral candidates know what venues are open to them for a career in research. And we need to include that population focus in all of our research. And in our RFAs, when a request for applications goes out, having one of the criteria be must address population health or culture of health, I think that'd be awesome. But you know, that's my love. So, by the way, if anyone wants to know about research careers in the VA, please see me, because I'm lonely. I'd like to have company. So I'd love to have another nurse in my coin. When we talk about engaging the nursing workforce, we need to foster that nurse advocacy, and we really need to address policy efforts. So I think that we need to scan the environment for that activity depending upon the population that you care for, whether it's the pediatric population with asthma, or it's the factory worker with diabetes, or whoever your population might be. You need to understand what's going on out in the community and legislatively to understand the potential impacts to your particular population. And then you need to join or create groups. Please join us at CNA. It's your organization. And there are student organizations also that you can join. You need to be able to talk to your peers and your coworkers and really foster that interest in advocating for your particular population and the culture of health. And you need to vote. And I'm not here to tell you who to vote for, what party to vote for, what platform, but make your voice be heard. Talk to your legislators. You can pick up the phone or send an email and talk to the people who represent you at the state or the national level and say, I'm a nurse and I vote and I believe, and then tell them whatever it is you need to tell them. They really like personal stories about your experiences taking care of patients with particular diseases, what their challenges are, and what you would like to be able to do for them to help them through a period of illness or to improve their upstream determinants of health. They really, truly do listen. And I want you to think of our foremothers, and my apologies to the men in the audience. We are so excited to have men in nursing. It's part of our mission to really increase minority representation. And I'm sorry, men, but you kind of fall into that minority group when it comes to nurses. But all of our forerunners, let's say, were women. So I call them foremothers. When you think about somebody like Mary Breckenridge, who got on a horse and mule and rode into rural areas to deliver health care to pregnant women. This is population health. This is driving a culture of health. And this was done in a time, an amazing university. You have got the world by a string, and I want you to go out and do great things. I want you to become an upstreamist. I want you to join groups like the group that I'm in, groups of ordinary people working to try and make a difference. You don't have to be a superstar or a rock star. You just need to have the desire to improve the culture of health for your fellow citizens. So now I want to just talk to you. I want you to ask me questions. I want you to tell me what you're doing. Tell me about your experiences.
I'm going to just grab my phone and run speedily in hills, so no one laugh if I fall down.
Don't run.
Here we go.
But if you fall down, you're in a great group of people.
That's an acute illness, so I'm just going to keep here.
But I want you to have an opportunity, if you're inside this time, to ask questions, right? You have questions about strategies?
Questions about strategies? You can use anything. This is the time to ask. I'm going to ask the first question then. And I have a question about, do you have, they're at a time where there's so much other action going on that I don't want anything today to fall through the cracks of what they take with them into their practice, right? So do you have do you think it's best to come to your healthcare team role, armed with facts? Do you think it's more compelling to talk about the emotional aspects of chronic illness? Like, what do you think are the strongest tools they can take with them to really bring this culture of health to their practice sites?
Thank you, Erin. That's a good question. And I think it depends. I keep saying know your audience. I think it depends upon what your group is like, where you're working, or the organization you're trying to impact. And I think you have to be armed with all of those things. I think you have to know a little bit about cost and impact. I think, though, you have to tell the human story. In my program of research, I'm really focusing on qualitative research because my coin already does big data, but I want to tell the human story. And I think if you can tell the human story of people who are suffering, of people whose upstream determinants are less than favorable, you can learn about where those gaps are and where they fall through the cracks, and that can drive some of the other data information that you're speaking of.
I don't have a question, but I'd like to add to the human story part of this. I'm Lisa, I'm a graduate student here at UConn, and I'm a nurse. So when you think of chronic health, perhaps you can think of me. I look healthy, I drive, I take care of my activities of daily living, and I have stage 4 breast cancer. I'm on weekly Taxol, and I'm pretty much the picture of health, although I am a bit obese, but I prefer to be that way. I like your definitions of health very much. I would like to add something to it. Instead of just well-being, I think all of us, whether we're dancing with a chronic illness or not, should try to find the joy in everything that we do. Because finding the joy in life, if you're a student and it's very difficult, if you're on weekly chemotherapy and it's not very easy, there are days, even in the difficult days, you can find the joy. Finding the joy in life fills your cup and makes you feel healthy, even though, after hearing my story, you might think I'm not so healthy, but I am. I am that definition of health that you speak of. I am chronic wellness, but I also find the joy in life. So when you think of chronic health, and you think of your patients when you go to work, think of me, because it's amazing what you can do when you have not just well-being, but joy in life. And it's not your job as a nurse to bring joy to patients, but boy, you really can. You really can make a big, big difference. And joy, I think, is much more beneficial to me than all the Taxol that I take. So congratulations on those that are graduating, and thank you.
Thank you. Thank you, Lisa. Thank you very much, because I think what you're describing is that holistic approach that includes that mind, body, spirit connection, and I wish you wellness.
Hi, I do have a question for you for our students going into practice. I recently heard from a student who graduated probably 3 years ago, and he's very discouraged because he sees the same people come back all the time. And he said to me, what's going on? I'm so discouraged. And I did tell him, you need to find out why they're coming back. Maybe you need to join a group. I gave him suggestions. But what bothered me a little bit was his burnout at 3 years post-graduation, and I don't want to see that to happen to these bright young people. Do you have any thoughts on that, or on chronic illness and our healthcare workers that are taking care of those patients?
That's a great point, and I too worry about those people who are experiencing burnout. I think we're approaching a time when new nurses' tenure at the bedside is growing shorter and shorter. On one hand, I'm so happy that they're seeking academic advancement, but it's taking them away from the bedside, and we need to educate brilliant bedside nurses, direct caregivers. I think that when we talk about a culture of health and upstream thinking, we need to remember that we can't force good health choices on people. We need to focus our grassroots efforts on achieving that equity with them and not for them. We need to engage that audience and help them find that choice and that desire for that improved health and that health equity, which they may have been in a multi-generational system of hopelessness. If you grow up in an environment where you feel you're not receiving equity on any grounds, health equity, political, socioeconomic, you might just give up. If you live in a food desert, it's easier to get that $1 hamburger from McDonald's than to get on a bus and make 2 transfers to get to a place like Whole Foods and find organic fresh produce. So we need to not only work on those upstream determinants from a policy and legislative perspective, but we really need to engage that audience and make that walk with them, not for them. So we have to really rally those groups of recidivists, as you're describing, and help them want to be a part of that effort. I have no magic answers for that, but my sense is that's where we need to start.
Hi, Cindy. Thank you for your discussion. And, you know, it's my belief that population health nursing is not done until we've reached the level of policy. And so can you talk a little bit, very briefly, about how we get these chronic health issues on the policy agenda, whether it's state or federal or even global levels?
Mm-hmm. I think that starts with nursing education, and we need to teach nursing students that they have a voice and how to use their voice. They need to have some basic understanding of policy, how policy is enacted, how nurses can advocate for groups, not only for the nursing profession, but for the populations that they care for. So that's very important. I think that all nurses need to be tuned into their state nursing organizations, even if you're not members. There are email blasts that go out from Connecticut, for example, that talk about policy and advocacy. I think that nurses need to join groups that have a voice and can work together collectively to drive change at the policy level. For us, I'll speak about Connecticut because that's what I know about. We have addressed things like chrome rubber playing fields for kids in high schools. Our policy, our position is that those are not good, they are not safe. We have addressed things like pending legislation that will allow medical assistants to give immunizations to infants. I think we've sort of blown away one that would have allowed dental assistants, not hygienists, assistants, with varying levels of training from 0 to 12 months to be able to fill a cavity. The dentist would do the drilling and prepare the cavity and walk away and allow that dental assistant to fill the tooth. So it's different things. Oh, that might seem very important to you, but people can get very sick sometimes from things like abscesses that can prevent a very, very difficult health situation. So follow your state organization and look at their government affairs work and look at the different populations that they're representing. And if you see something there that's not within the needs of your own particular policy, your particular population needs, join that organization and advocate for your group. We have a thriving GRC group right now made up of individuals who are representing their particular populations. Some of it's in women's health, some of it's within the framework of cognitively, intellectually disabled people. it really runs a gamut of particular populations in the state. I think also you can look at opportunities to learn how to advocate. Lisa and I went to Washington a few years ago with the AACM, and we did visits to Capitol Hill. They won't call it lobbying, they call it visits, and advocated for the profession and for the populations we serve. It was an eye-opening experience, and it's open to students. I would encourage everyone to look into that.
We have time for one last question, and this one's from a student, so I feel like she deserves a gold star. So, there you go.
Hi. I feel like mental health is becoming a much more significant problem in younger ages than we used to see it. I don't feel like I really even learned what anxiety was until I was like 16 or 17. And I feel like mental illness can be considered almost an upstream. It is a chronic illness in and of itself, but it can also be considered an upstream to other chronic illnesses, given that chronic stress causes so many different illnesses, as well as it can kind of be like a predetermining factor for alcohol, drug use, smoking, etc. So what do you think we as RNs and what can we do in the community and in the hospital setting to kind of tackle that? Because I don't know, there are like 5-year-olds who have mental illness now, and how can we kind of approach that subject when parents probably are like, there's no way my kid could have mental illness?
Yeah, it's such a hot topic right now too, politically, because on one hand, we decrease services for mental health care, but we tend to blame things on people with mental illness. So on one hand, we can blame mental illness. On the other hand, we do nothing to address it early and really help create wellness in those populations. I think sometimes too, there's such a stigma about mental illness that as nurses, we feel a little awkward about asking people about their histories. You know, how do you feel? In really pursuing those questions about depression or anxiety and so forth. I think we need to identify that early, and we need to destigmatize. We need to let our patients know that it's okay to talk about those things. It shouldn't label someone, but we can't really help them unless we understand what they're feeling if they hide it from us. I think we also need to legislate. We need to advocate at the legislative level for equity between acute illness, or what I'll call physical illness, although I consider mental illness to be physical illness also, and mental health. I think that they really shouldn't be separated. I think that mental health deserves the same level of funding and access to care. When I did my windshield survey of my town, when I was in that community health class that I love so much, and I live in a small town of 4,100 people, I talked to my resident state trooper about his views of our town, and I found that resident state troopers are not only cops, they're social workers and a whole host of other things. And he said, I know just about every house where there's an individual suffering from mental health issues. A lot of them are adolescents, and when the parents call me because they don't know what else to do, I can't take that kid